So how can one go about sort of setting a reasonable yardstick? There's sort of 17,000 possible, diseases
Well,
that
I
can be
mean,
treated.
the first thing that you have to understand is most insurance policies don't go service by service and say you're covered for this or not covered for that. Most health insurance policies have broad categories of service and then a caveat like if it's medically necessary. In some cases, they do have exclusions. We don't cover. An example might be fertility treatments, and I'm making no judgment about fertility treatments or not, but you might find insurance policies that don't cover infertility. We could have a debate about whether or not we should mandate coverage for infertility, in which case we would be saying that not only is infertility an important thing for people to buy coverage for, but it's so important that the federal government and therefore the taxpayers is willing to subsidize it. And again, that's a policy choice that don't have a particular position on, but you realize the trade-off is it doesn't come for free.
Mhm.
Individuals have to pay for that. And so the question with the policy question is how granular one would want to define these particular set of services.
Now, as I understand it, the Institute of Medicine at some 50,000 foot level said kind of a reasonable standard for overall coverage to, to establish the essential health benefit is kind of what a typical small business would generally cover is kind of the way that
Basically,
in
right?
and you got the Institute of Medicine committee got some flack for that because some people wanted to see that package look a little more like what say IBM would cover or a big generous a sort of large relatively
Right.
generous
So
employer.
the Institute of Medicine is good at a lot of things, and the people on the panel were very dedicated and a wonderful group of folks. But a lot of these things end up being policy trade-offs more than scientific judgments. And of course, the administration chose an approach which allowed states some flexibility in what they were going to do based on a range of different options. Large plans, state plans, things of that nature. But the IOM committee was worried about this trade-off between essential benefits and the expansiveness of it and healthcare spending and the overall cost of the Affordable Care Act. And I think the concern, which I think incidentally remains a concern, is on a day that we're facing sequester, that if we're not willing to finance the benefits that we are trying to subsidize, the ramifications for the country could be quite severe. And these are very big issues with very big policy trade-offs. So everyone might come down differently on those particular questions, but we thought that the benefit package remember, in say small businesses, which actually is not that different in many cases than large businesses, because the differences might have to do with the degree to which those services are covered, how high are the coinsurance rates, things of that nature. And the Affordable Care Act mandates those, but we picked a standard that was as you described.
Now, by the way, I just for our listeners, you could imagine that you go down a list of cancer care and you say, wow, we should be pretty generous in cancer care, and we go down and we cover a bunch of conditions, and in each case you say, wow, it seems pretty reasonable to be pretty expensive in what we cover, and then you look at the overall price when you're done, and if it's really pretty high, we have an issue. And one of the questions I have for you is, are we going to see in part because of issues around the essential health benefit, that younger people are going to feel a sense of sticker shock when they start to participate in these exchanges because they're
So
basically buying a more rich insurance package than they would have bought it, before health reform had they chosen to buy this?
I haven't seen that. That's a wonderful question. I have not seen the numbers, but that is certainly the concern. I think the other thing that's important to understand, which is frustrating for individuals, is just because a service is covered doesn't mean it's covered for you in a particular clinical situation. So it might be covered, you might be covered for MRI if you have a concussion, but maybe not for back pain. Or you might be covered, for a particular medication if you have one set of clinical indications and not covered for that medication if you have a different set of clinical indications. And most insurance policies now will have some mechanisms for trying to manage utilization of the services which are clearly covered in the policy. So my general view is that coverage policy is an exceptionally clunky way to try and make sure people aren't getting denied needed care. And I view it more as an administrative necessity in the plans. But the real questions that concerns that people have, I think, are going to be less to do with what's covered and more to do with how much access people have to those services conditional on being covered. There are examples of those things like uh, infertility treatments where you might worry about whether they are covered or not. But for the most part, for the vast bulk of things like cancer care, almost every aspect of cancer care is going to be covered. The question is when you get access to those types of cancer care, and how and who makes those decisions and what type of insurance policies you have. And that's very hard to do through simple coverage determinations because it relies on the person.
I want to shift gears a little bit, if that's all right. And
Mhm.
because another area that you've worked on is sort of general growth in medical care costs. Are we basically going to have 100% of the economy going to Medicare in 2050 or whatever day? I mean, how scared should I be about the long-term increase in uh, Medicare and Medicaid and other insurance costs? And
Well, I think you should be both very scared and somewhat soothed. Um, with regards to with regards to Medicare, the Affordable Care Act placed Medicare on a trajectory which, at least on paper, is amongst the lowest rate of healthcare spending growth that we would have ever achieved if we're successful. The challenge is, of course, to make the targets in the Affordable Care Act a reality, and there's a lot of work being done now at CMS and other places to try and do that. Um, I personally am on the cautiously optimistic side about our ability to control spending growth, as I think that providers have really turned the corner in terms of their attention on controlling healthcare spending growth. And they understand that the nation can only afford a certain amount of money, and they see through falling fees from a number of different sectors that type of pressure. So I'm optimistic that providers, who are really the fundamental foundation of our healthcare sector, are working hard to control spending, and that payers are working hard to put in place the systems that provide the incentives to providers to be successful should they control spending growth.
what are providers actually doing that's bringing cost growth down?
Well, first, let me emphasize bringing cost growth down. So that doesn't necessarily mean lowering spending, just lowering the rate with which spending is rising. So some of the answer to lowering spending growth isn't what you're cutting out of the system, but what you're not adding to it. But in a nutshell, for example, there's a dramatic reduction in the use of imaging. There is a reduction in the use of certain cardiac procedures. You see providers that have certain incentives shopping around for care to purchase care from less expensive sites. You see attention to certain types of medications in particular areas, and I might add sometimes that involves using more medications in the case of chronic disease and perhaps less in other cases. But there's a newfound attention, I think, across the spectrum to ways of managing care with perhaps using remote ways to contact patients. There's a lot of emphasis on case management of individuals. Not all of these interventions, incidentally, lower spending. Many of them might, in fact, increase spending. But this overall attention to managing patients with chronic disease, cutting out services that are unimportant matters. There's an effort by the American Board of Internal Medicine, the ABIM. They've launched a campaign called Choosing Wisely to identify services that medical professionals believe are unnecessary, wasteful, perhaps harmful. And they've been getting a lot of publicity for this list of services and trying to work with physicians who are now facing more fiscally difficult times to get them to restrict the utilization of these services that people think add very little value. So I don't think there's a particularly big answer to what they're doing as much as everyday little things providers are trying to become more efficient in how they manage care and how they try and coordinate care across the many different sites of care where patients find themselves.